we should ask is, where is the problem? To have an harmony, the face mustn't show any tension or dysfunction at rest. The midlines must coincide in regard to each other and to the face. The facial aesthetic depends strongly on the transverse dimension. If we take a look at this young woman, we see that her face is quite balanced and harmonious. But the harmony disappears as soon as she smiles. What we are looking for is the gingiva show, both when the smile is moderate and when it is full. We are also looking for the dental show. What we want to see is the maxillary denture completely, but not the lower denture at all. Another important thing is to look for the shadow zones of the smile. On these 4 pictures published in the AGO, you can see how the shadow zone of the buccal corridor better simply by modifying the width of the transverse dimension of the dental arches. We must take into consideration the position of the denture on the face as the final determinant of our treatment planning. Here is another example showing us the role of the correction of the transverse dimension in the bettering and the quality of the smile. We will now deal with the therapeutics by saying how to define the objective of the treatment, when we should correct transverse problems, and with what therapeutic means. In order to determine the treatment planning, we always use the lateral VTO, but also the mini-frontal VTO. We are looking to develop skeletal and dental objectives in order to create a harmony and an optimal neutrality of the face on an aesthetic and functional level. The VTO is the only means to make a link between the diagnosis and the treatment planning. Without VTO, why make a diagnosis? The VTO will be sagittal and frontal. Superimpositions will help us to individualize the VTO on the treatment chart. This will enable us to see all the objectives of the treatment at once. We mustn't forget that individualization is one of the key points of the bioprogressive concept. The main question is to ask whether there is enough room to make transverse expansion. Yes or no? What we are looking to do is to put in relation the diagnosis and the treatment planning at a time when there is more talk about therapeutic means than diagnosis. And this is the only means to pursue the mechanical limits before having problems. Only a precise diagnosis allows to know from where and how to perform the expansion. In the maxillary, in the mandible, or both, alveolar, basal, or both, orthopedically or surgically. Only the clinical examination, the diagnosis, and the chosen therapeutic means should guide us. On this picture, an alveolar expansion will be possible if necessary. Whereas in this example, a maxillary disjunction is the only possible solution if we need expansion. It is the only way to avoid what we see on these pictures taken during surgery. Look at the roots of the teeth. These findings are more and more frequent. We can say thank you to these so-called modern techniques. In consequence, if an expansion is not possible, we will treat according to the diagnostic arch form. However, if there is room for expansion, we will then be able to gain some arch length in order to obtain a non-constricted denture, which is thus unlocked, in order to make the smile more aesthetic and to help correcting functional problems. If we take these elements into consideration, we will be able to choose an arch form called therapeutic, which takes into account the expansion required. We then build the lateral VTO, which will enable us to measure the change in the antero-posterior position of the lower incisor. In this example, it is moved forward by 2 millimeters. The therapeutic arch form is thus repositioned 2 millimeters in front of the initial arch, and the teeth will move towards the therapeutic arch. Hence, we can visualize all the dental movements to be realized on the mandibular arch. Next, the therapeutic arch form is reported on the maxillary arch by positioning the continuous line in the middle of the occlusal face of the upper molar and 2 millimeters behind the incisors. We can measure the total quantity of expansion on the other side, here, that must be realized on the maxillary arch. Thanks to the cephalometric synthesis, we know the necessary quantity of basal expansion. The difference between the two indicates the quantity of alveolar expansion that must be realized. Thanks to the lateral VTO and the mini-frontal VTO, we get a tri-dimensional therapeutic model. Now we have to know when to realize this transverse correction. I believe we all agree here to say that the treatment should begin by unlocking the dysfunctions, the TMJs, the mandible, and the denture. At the beginning of the treatment, we must treat the dysfunctions to optimize the environment and work on the structures to modify the shapes. The unlocking should be done as early as possible. The unlocking unfolds into many steps which have to be followed in strict order. First, functional training with the treatment of all dysfunctions. Second, the correction of the transverse problem. Third, the leveling of the maxillary and the mandible. Fourth, the orthopedic correction of the maxillary. Fifth, the orthopedic correction of the mandible. As you can see, managing transverse problems is the first mechanical phase of the treatment. Now let's look at the mechanical means. All means are usable under 2 conditions. Which ones? First, that they enable us to reach the determined objectives according to the individualized diagnosis of the patient. Second, that we have corrected the functional problems. Otherwise, there will be a relapse. To act on the alveolar maxillary arch, I use the quadrics, including on the second deciduous molars and the bihelix for the alveolar mandibulary arch. To act on the basal bone, I use a Haas disjunctor in orthopedic cases and a Irax disjunctor for surgery cases for the maxilla. For the mandible, the solution is always surgery And after having used bone distractors, I always use distractors fixed on teeth only. Consequently, the diagnosis conditions are therapeutic choices. Let's start the quadratics by reminding you a few fundamental principles of constructions. For mechanical reasons, it should be made in LG0.036. Personally, I have always made my own quadratics. The first distal loop must be regarding the distal face of the first molar. The anterior loop must be regarding the mesial face of the first bicuspid. The anterior part at the back of the incisive retropapilla is perfectly rounded in order to respect the distribution of the force. Also, we must respect a symmetry of construction, a symmetry in a mirror, unless there is an exception. The quadratics is pre-activated before it is sealed on the teeth. It is pre-activated in expansion by placing the unique jaw of the three jaw pliers outside of the quadratics between the two anterior loops. We must pre-activate the quadratics in order to make a distal-palatal rotation of the upper molar with the unique jaw placed inside the body of the quadratics between both lateral loops. The quadratics can also be adjusted with or without torque. We must beware of vertical effects because the buccal rod torque will induce an intrusion of the molar and an exclusion of the molar on the opposite side. If we do not wish for the molar to move vertically, we must keep a perfect symmetry of the torque. Also beware of the sealing of the quadratics, which can create a differential torque. The quadratics, like any orthodontic device, will respect standards for these, which are a good direction of the force, a good distribution of the force, and a good duration of the force. The degree of the force will have to respect a good level of biological forces, which is about 250 grams if we refer to Brignani's work. Here are a few examples of expansion and of molar rotation. Look at the correction of the unilateral crossbite and look at the correction of the molar rotation. Here we have a strong molar rotation to correct and an expansion to make on the premaxilla. Look at the backward movement of the molar, which comes with the molar rotation, which is useful to help correcting a little class tube. And then the gain of the gain in arch length on the premaxillary level. Of course, this will help the pursuit of the functional education. Let us look at the case of Laurelien, who has an oral breathing and a lingual dysfunction. She came to see me for the aesthetic problem of her denture, a maxillomandibular discrepancy, and a dental closing. We noticed the presence of a dibolus-shaped occlusion. Her father refused the extractions that another practitioner suggested. The class 2 is alveolar, and the typology is mesofacial. Thus, there is a low degree of skeletal difficulty. On the transversal level, there is a maxillary and mandibulary endoalveoli. The dental crowding is of 6 millimeters. The diagnostic arch form is now tapered. Depending on the diagnosis, the chosen therapeutic arch form is normal. According to the lateral VTO, the lower incisors is placed 2 millimeters forward. We reposition all the mandibular teeth according to this criteria. Then we can visualize all the dental movements to do on the mandibular arch. Here we can see the total expansion to be done on the maxillary arch. According to the frontal X-ray, we know that this expansion will be only alveolar. In the same way, we can see the dental movements to be done on the maxilla. The VTO is then performed with an expected length gain of 8 millimeters only by the expansion of the arch. Look at general superimpositions. The superimpositions of the arch form and by zones. After starting the functional education, we start the mechanical treatment by the transverse correction, which is exclusively alveolar by using a quadhelix on the maxilla and a bihelix on the mandible. After that, we do the mandibular arch and maxillary lateral sectors leveling. Let's stay bioprogressive. We level the maxillary incisile sector and we put into place the 41. We stabilize the arches. We correct the class 2 with class 2 elastics on sweep sections on the maxilla and the utility arch on the mandible. Here is the finished result. The cast of the end of the treatment. We can see that our expected objectives have been met. Here are the transverse modifications on the maxilla and on the mandible. Here is the lateral cephalometric tracing at the end of the treatment, and the frontal tracing. Here are the superimpositions at the beginning of the VTO and at the end of the treatment. Notice that thanks to the unlocking, the upper incisor has been pulled backward less, and it's a good thing. And here is Lauren at the age of 16, 3 years after the end of the retention. The quadhelix can be used on very young children without any problem. Here is the case of a 3-year-and-a-half boy with oral breathing and lingual dysfunction, a bilateral crossbite, and an anterior overbite. The quadhelix is used right away. And here is the result that we obtained 4 months afterwards. In the case of a basal deficiency of the maxilla, depending on the age of the patient and the state of the sutures, the disjunctions will be done orthopedically or surgically. For a rapid palatal expansion, we will use a Haas disjunctor with 2 or 4 bands. For surgically assisted disjunctions, we will use a Hyrax disjunctor. In both situations, we can move the jack screw in anterior position with a posterior hinge if we want an action exclusively on the premaxilla. We can also use 2 jack screws for a differential expansion in the anterior and posterior part of the maxilla. Here is a 9-year-old boy with permanent oral breathing, significant snoring, sleep troubles, and postural problems. A full class 2 with endomaxilli and V-shaped maxilla. A skeletal class 2 with a dolichofascial typology and a transverse maxillary deficiency of 7 mm, both basal 4 mm and alveolar 3 mm. The cut beam exam confirms the maxillary deficiency, both basal and alveolar, and the mandibulary alveolar insufficiency. We have performed a maxillary disjunction with a Haas disjunctor on 2 bands and 2 bonded hooks. The functional training and the disjunction have been performed at the same time because the child was living far from the office. The transverse action has been completed thanks to the action of the quadrics to reshape the alveolar arch. The quadrics is put into place systematically on the day we remove the disjunctor. Here is the result that we get at the end of the interceptive treatment. Here is the evolution of the width and of the maxillary arch form, and the bettering of the class 2 and of the overjet. On the mandible, the means to correct an anterior clouding are often limited to the vestibulization of the incisors, which we do not always recommend, the stripping, I never perform any at the beginning of the treatment, the extraction of 1 incisor, which will enable us to gain about 4 mm, but will create important problems of occlusion with a class 2 canine and a risk of supraocclusion. The extraction of 2 premolars from 13 to 15 mm is too much, and it will force us to also extract premolars on the maxilla, even if a disjunction was possible, preventing all hopes of regaining a satisfactory breathing function. Just remember the cases we saw at the beginning of this presentation. For about 10 years, we associate maxillary disjunctions and transverse distraction on the mandible, every time it is necessary, of course. This procedure enables us to get the necessary room by the millimeter. In the first case of distraction that I performed with my surgeon friend, Dr. Christian Paulus, we used a bone distractor screwed in this symphysis. It was a Brody syndrome with a high backward mandible. Unfortunately, we only have panoramic X-ray showing the distractor in place. The correction of the Brody enabled a real unlocking and an important horizontal growth of the mandible. I don't have any other documents on this case, and it is the only we treat this way. Indeed, the post-operative recoveries are not good, and we now prefer to use another method. As an illustration, there is 13-year-old Elias who has a class 2 with an 8 mm overjet and especially a severe crowding in the mandibulary arch. He has allergies and breathing difficulties, and in such cases, I generally refuse to treat by extractions. On the models, we evaluate the TALD to be -9 mm. The skeletal class 2 is induced by the backward mandible on the typology of the dolichofascial tendency. there is a maxillary and mandibulary underglassing. Depending on the age, we decide to perform an orthopedic maxillary disjunction and a surgically assisted mandibulary dissection. For more than 10 years, we have been using distractor fixed on teeth. The distractor is fixed on teeth. It is soldered on 4 bands. The corticotomy is performed preserving at most the periostis, and we start the expulsion for the week afterwards. After a short incision in the buccal sulcus, the subparietal undermining is limited to the preparation of the osteotomy site, preserving the normal muscular anatomy of the chin. The symphysial action is performed by an ultrasound-bound scalpel from the inferior border to the roots of the incisors. With a traditional osteotome, we cut the bone between the roots until the alveolar ridge. This bone cut can be between the central incisors or laterally if there is no space between the roots. The activation of the distractor demonstrates the completion of the bone cut. After putting the distractor into place and performing surgery, we wait for a week before starting to activate the distractor from 0.5 to 1 millimeter a day. The stabilization phase must last from 8 to 12 weeks, and I recommend not to remove the distractor during the leveling of the mandibulary dental arch. We can control the quality of the distraction with the cone beam. 2 months after that, the cone helix is put into place to work on the shape of the maxilla. And 4 months after surgery, without removing the distractor, we start the phase of mandibulary leveling. Then the treatment becomes standard with the maxillary leveling. Notice the spontaneous correction of part of class 2. Next, we complete the correction of the class 2 with intermaxillary elastics. A torquing utility arch is used to position incisors. Here is the obtained result. The frontal cephalometric control and the profile control. This 51-year-old patient came to see us from a lower and upper crowding, which both sides are formed from an aesthetic point of view. There is a low class 2, a skeletal class 1, and problems are mainly transverse. We decide to perform a maxillary disjunction and a mandibulary dissection, both surgically assisted. Of course, the patient is aware of the opening of the diastema. The following of the treatment is standard with the leveling phase, the positioning of the 31, and we are even forced to use a contracting arch, which enables us to upright slightly the mandibulary incisors. Here is the finishing phase, and here is the obtained result. The X-ray control, and 2 years after the end of the treatment. Now, what are the advantages and inconveniences of these procedures? An aesthetic bettering of the smile, the improvement of the lingual and breathing function, a real osseous gain with periodontal improvement, a fast treatment of the clothing with reduced dental noise. What are the side effects? In a study from 2002 to 2004, and on 124 cases, Wolfgang Katter, a German surgeon, found 7% mucosal scars, 2% reosteotomy, 2% split tooth, and 2% instability. The correction of transverse problems, whatever the method, must come with a successful educational training. These results will certainly be much improved if we did this study nowadays. As far as I am concerned, in all cases treated with mandibular dissection since 10 years, we have only encountered one severe problem: the destruction of the root of the 41 in the case of this 20-year-old young lady. It's the reason we separate now the bone with an osteotomy and not with a piezo surgery. In conclusion, can we consider the correction of the transverse dimension a key factor in orthodontics? The answer is yes, because it enables the use of a real quadridimensional mechanics. It also enables to treat without extractions in every difficult case on a functional or breathing and parodontal, and as is the case of this 8 here, all girl. The treatment is standard using the bioprogressive principles in order to get an ideal functional orthodontic occlusion and a correction of the breathing and of the tongue posture. Preserving the facial aesthetics, the stability is maintained thanks to the good functional result. In order to do this, it is necessary to consider the patient globally, to work on his teeth. George Catlin, an American, had written this book, Shut Your Mouth and Save Your Life. It was in 1870. More 1 century. I've been very happy to be with you this afternoon, and I thank you for your attention.
Okay.